Ladies and gentlemen, thank you for joining the Lake Superior Quality Innovation Network, Understanding Opioids, Neurobiology, and Treatment webinar. Your host for today, Mark Lausch, will begin.
Thank you, Katina. Hey, everyone. Welcome to today's presentation. Now, the official title was actually too long to put on the slide here. So it is Understanding Opioids from Neurobiology to Treatment, including strategies to combat overdose and misuse. So I'm going to cover a lot of material today, and I hope you find this interesting. My name is Mark Lausch. I'm a licensed master level social worker and certified advanced alcohol and addictions counselor. Our webinar today is brought to you by the Lake Superior Quality Innovation Network, which includes Michigan, Minnesota, and Wisconsin. And I work as a clinical quality consultant for the Michigan QIN MPRO. Thank you, Jeff. A couple of disclosure statements I need to make. No commercial support has been received for this learning activity. I have no reported conflicts of interest, and there are no planned or conflicts of interest. For CE credits or a certificate of attendance, you must attend the entire session and complete the online evaluation. Well, actually, you'll complete the evaluation by the instructions I give you at the end of the thing. At the end of the presentation. So we encourage everyone to complete the evaluation. Those of you that aren't getting CEs, an evaluation will come up on the screen, but those of you that will get CEs, I will give you those instructions. Next slide, please. Nursing continuing education credits are available for attendees in Michigan, Wisconsin, and Minnesota. I'll provide you with the link to take the evaluation and receive your certificate at the end of the presentation. Social workers in Michigan, Minnesota, and Wisconsin are also eligible for an hour of continuing education credit also. And I'll show you that information at the end of the presentation. Now, for the nursing Cs, you can also use this for your 1 hour of pain management continuing education too. And the same thing holds true for Wisconsin. So all three states will get CEs for social work and nursing. And in all three states, the nursing CEs will count for the pain management part of your CE requirements. Okay. All right. Our objectives today are shown on the slide, and that's a picture of me there in case you hadn't figured that out. What I really want to do today is provide you with an overview of opioids as a psychoactive substance, taking into account neurotransmission and neurobiology. I also want to talk about opioid abuse, addiction, and dependence, and some of the promising treatment modalities that can successfully treat opioid addiction. And finally, I want to touch briefly on some efforts at the national, state, and local levels to address the recent upturn in opioid misuse and overdoses. Before I go on, I'd like to mention 4 individuals who were instrumental to me in learning about and understanding alcoholism, addiction, and opioid dependence. The first is Dr. David Olms. Dr. Olms, is a physician and addiction medicine specialist. He's currently based in St. Louis, Missouri. In the 80s, he produced a line of videos and written material about the disease concept of addiction that really were for me when I was just beginning in this field of study. They really helped develop my foundation of understanding addiction as a disease. The second person is Father Joseph Martin, or better known as Father Martin. Father Martin was a Roman Catholic priest, a recovering alcoholic, and an author, speaker, and presenter on alcoholism and drug addiction and 12-step recovery. Father Martin really helped me understand the spiritual nature of recovery from addiction. Dr. Carl Christensen, who is a physician, addiction medicine specialist, and instructor at Wayne State University. His knowledge of addiction and reward pathways helped me understand the importance of this area of study, and it is the framework that he uses that I will be using today to help you understand addiction as a brain disease. And finally, Robert Julian, MD, the author of the book Primer of Drug Action, which would be a most valuable addition to any addiction medicine library. It's in its 14th edition now. And one final mention on a personal note. And this is the reason I put my picture up here. I am a recovering alcoholic and opioid addict. I have experienced opioid addiction, withdrawal, and recovery. I was also a patient in a methadone maintenance program for 8 years. So I can tell you that I tell you that so you can put a face to addiction. They always talk a lot about the faces of addiction, and the message I want to get across with this is simply that addiction can impact just about anyone, regardless of race, gender, education, socioeconomics, and living situation. So we're going to move on and get down to the meat and potatoes of this presentation. So what are opioids? Essentially, opioids are medications that are used to relieve pain. They reduce the intensity of pain signals that reach the brain and affect those brain areas controlling emotion, which diminishes the effects of painful stimuli. Medications that fall within the opioid class include hydrocodone, which is Vicodin, oxycodone, which is also marketed as OxyContin and Percocet, morphine, codeine, buprenorphine, fentanyl, and others. Hydrocodone products are the most commonly prescribed for a variety of painful conditions, including dental and injury-related pain. Morphine is often used before and after surgical procedures to alleviate severe pain. Codeine, on the other hand, is often prescribed for milder pain. In addition to the pain-relieving properties, some of these opioids can also be used to relieve coughs and severe diarrhea. So now let's take a look at the different types of opioids. There are basically three types. The natural opioids, those are found in the opium poppy or Papaver somniferum. This plant is grown extensively for illegal drug production in Mexico and in Afghanistan, and the medicinal raw opium that manufacturers like Mallinckrodt and Merck use in the manufacture of opioid medications typically come from either Turkey, India, or Tasmania. So examples of naturally occurring opioids include morphine, codeine, and opium powder. The next group is semi-synthetic, and these are derived from naturally occurring opium alkaloids, but are manipulated somewhat in a laboratory and by scientists to make the substance. And these include hydrocodone, oxycodone, and hydromorphone. Synthetic opioids are synthesized from other molecules, not from naturally occurring sources. And examples of true synthetic opioids would be methadone and fentanyl. All of these substances, while differing in molecular structure, all have the same effects in the body physiologically and in the central nervous system. And on the slide here, I noted some physiological and central nervous system opioid effects. Common side effects of opioid administration include respiratory depression, decreased heart rate, nausea, constipation, which is why they're used to treat diarrhea, dizziness, vomiting. You can become physically dependent, develop tolerance and dependence. The central nervous system effects include euphoria, which is a major reason why people misuse opioids, sedation, dizziness, mental confusion, lethargy, and impaired cognition. In some individuals, the effects of opioids are dysphoric, which is the opposite of euphoric. And this can vary from person to person. And I personally know several people who have been prescribed opiates and reported extremely dysphoric experiences, nausea, vomiting. And I've often wondered why that happens, but it just depends on the individual and their response to it. So now we're going to begin to look at neurotransmission and neurobiology of opioids. And what I have up here is a schematic of a typical neuron in our brain. There are billions of these. Actually, there's two neurons there, the top one and the bottom one. And there are literally billions of these in our brain. And opioids exert their effect in many parts of the body. There are opioid receptors in the brain, the spinal column, and the digestive tract. Naturally occurring opioids in the body include dynorphins, enkephalins, endorphins, and endomorphins. So these are those natural peptides that the body produces that mimic the effect of opioids. Opioids act by attaching to specific proteins called opioid receptors, which are found in the brain, spinal cord, digestive tract, and other organs in the body. When these drugs attach to their receptors, they reduce the perception of pain. So, in neurobiology, information is communicated in the brain via a process called neurotransmission. Neurotransmission involves a variety of chemical substances called neurotransmitters. One such neurotransmitter is called dopamine. There are other ones, serotonin, norepinephrine, acetylcholine. There's quite a few of them. In the normal communication process, dopamine is released by a neuron into the synapse, which is the small gap between the neurons. The dopamine then binds with the specialized proteins called dopamine receptors on the neighboring neuron, thereby sending a signal to the receiving neuron, the bottom one there in the picture. After the signal is sent to the neighboring neuron, the dopamine is transported back into the neuron, from which it is released by another specialized protein called the dopamine transporter. So there's a reuptake back into the top neuron. So drugs of abuse are able to interfere with this normal communication process in the brain. Opioids, for example, block the removal of dopamine from the synapse by binding it to the dopamine transporter. So this results in a buildup of dopamine in the synapse. In turn, this causes a continuous stimulation of receiving neurons, and we believe it's probably responsible for the euphoric effect that people experience from opioids. Some people experience from opioids. So it's a kind of a flooding of the neurons of dopamine, okay? And kind of to put it in a kind of a different way, antidepressant medicines work kind of in the same way. Medications such as selective serotonin reuptake inhibitors and selective serotonin norepinephrine reuptake inhibitors exert their therapeutic effect by blocking the reuptake of serotonin and norepinephrine from the synapse, thus allowing the receiving neuron to take in more of the serotonin or the norepinephrine to help stabilize mood. So in the same way that opioids work in neurotransmission, some antidepressant medications work in similar ways. So I thought I'd just throw that in to throw a different perspective on it. Okay, now we're going to get into brain chemistry and brain functions and parts of the brain. And I have to tell you, I'm not a scientist. I know enough to be dangerous, but I felt I would be lacking by not presenting this information to you. So, one pathway important to understand the effects of drugs on the brain is the reward pathway. So the reward pathway involves several parts of the brain, and these include the ventral tegmental areas of the VTA, the nucleus accumbens, or the NA, and the prefrontal cortex. So when activated by a rewarding stimulus, now we're talking about the reward pathway here. So when activated by a rewarding stimulus, drugs, food, sex, information travels from the VTA to the nucleus accumbens and then up to the prefrontal cortex. So using opioids as an example, we can describe how drugs interfere with brain functioning. So when a person ingests opioids, it travels to the brain via the bloodstream. Although it reaches all areas of the brain, its euphoric effects are mediated in a few specific areas, especially those associated with the reward pathway via the nucleus accumbens, the ventral tegmental area, and the frontal cortex. So the NA, the nucleus accumbens, plays a significant role in the reinforcement of pleasure and the reinforcement of learning. So it is really the pleasure center of the brain. The ventral tegmental area actually supplies the dopamine to the nucleus accumbens, and is much like the gas tank of your car. So it fuels the pleasurable feelings by releasing the dopamine that provides the euphoria experience when opioids are ingested. And in combination with the euphoric feelings supplied by dopamine from the VTA and the reinforcement of these feelings by the nucleus accumbens, the cycle is completed in the frontal cortex, which becomes impaired, which then causes a reduction in the person's insight and judgment. So in simple terms, what you get is essentially awesome feelings, let's do it again. Really, that's not so bad. Then I'm using Oxycontin, heroin, or Vicodin, and then I won't let all those bad things I heard about to other people happen to be, and I won't ever use a needle, and I can't wait to do that again. Then I use it again, and I get this awesome feeling, and then it's like, let's do that again, and my prefrontal cortex says, geez, that wasn't so bad. Oxycontins are only $30 to $40 a piece, and I make a lot of money, and I can afford those, and if I can't afford them, I'll find a way to get the money, and it won't be so bad, and I'll never develop those problems other people do. So as you can see, the pleasure center gets stimulated, and the frontal cortex becomes impaired, so the person has a difficult time understanding the danger that they may be in with this cycle. Just a reminder that it's important to remember that the reward centers impact all the pleasurable activities that we love to participate in. For me, I love pizza. I look forward to eating it. I love the taste of it. I seek opportunities out to get pizza. But I also know that pizza is huge calories and it's fattening and it's not good for my heart. Yet I continue to want it and crave it. So this behavior of mine can be explained by activity in the nucleus accumbens, the ventral tegmental area, and the frontal cortex. So just another non-drug related kind of behavior that is impacted by the reward centers. And we also need to remember that it is these neurobiological functions that precipitate the social, emotional, and behavioral manifestations that occur in addiction or other behavioral compulsions. All right, so now we know a little bit about neurotransmission and the reward centers and then the NA, the VTA, and the frontal cortex. We're going to move into talking about tolerance and withdrawal. So tolerance occurs when a person has a diminished response to the drug. And this occurs when the drug is used repeatedly and the body adapts to the continued presence of that drug. Tolerance occurs when the person no longer responds to the drug in the way that they initially responded. Stated another way, it takes a higher dose of the drug to achieve the same level of response achieved initially. And if you ask any opioid, alcohol, other type of addict, they will frequently tell you that the first several times they used their drug of choice were the best, and that all other times after that are simply attempting to recreate that experience, which is very difficult to do because tolerance develops, sometimes with opioids especially, rather quickly. An individual cannot think, desire, or use their willpower to prevent tolerance from happening. With repeated administration of opioids or other substances such as alcohol and benzodiazepines. So withdrawal is caused when the person who is dependent upon opioids stops taking them. The effects of the withdrawal are generally the opposite of the drug that is being used. For example, for opioids and other sedatives, they usually cause central nervous system excitation, insomnia, anxiety, restlessness, drug cravings, tremors, and even seizures. Now, opiates don't generally cause seizures. That would be with alcohol or benzodiazepines or other sedatives. So with stimulant withdrawal, that causes the opposite of the effects of the stimulant drug. Central nervous system depression, lethargy, slowed cognition, increased need to sleep, somnolence, those types of reactions. So tolerance and withdrawal do not imply addiction. So, for example, if 100 people were given therapeutic doses of OxyContin for 2 weeks, and after that 2 weeks, the OxyContin was abruptly discontinued, about 95 out of 100 of those would have physiological symptoms of withdrawal. They would be probably mild flu-like symptoms, and many people wouldn't even attribute these symptoms to the opioid withdrawal. They wouldn't even know that, they wouldn't even associate that with it. But the other 5 of those 100 would probably continue to do whatever they could to get more OxyContin. And these people would be displaying signs of early addiction. But I'll talk about a little bit more about that in just a minute. Okay, opioid withdrawal is not life-threatening despite protestations to the opposite, okay? It is not life-threatening. However, there may be situations where an individual could be compromised by other chronic conditions such as heart disease, COPD, diabetes, who might develop life-threatening complications from the combination of opioid withdrawal and their chronic condition, okay? So, but opioid withdrawal and not in and of itself is not life-threatening. Withdrawal from opioids, while painful, and generally more psychologically painful than physically, usually peaks within 72 hours and subsides over the next 5 to 10 days. Depression, agitation, mental confusion, anxiety, and intense drug craving and insomnia can last for several weeks to months depending on how long the opioids were used. This is a frequent cause of relapse in people attempting abstinence-based recovery from opioids. The drug craving, the agitation, the anxiety, and the insomnia. it frequently causes people to go back to using because you try going 5-6 days with 2 or 3 hours of sleep and having to work or live a normal life, and it becomes very, very difficult and very tempting to use again when you know that those symptoms will go away if you take that drug. For minor cases of dependence without addiction, the symptoms may only be mild with a full recovery in a few days to a couple of weeks. So these would be for people that might have taken opioids for a pain situation, a broken arm, broken leg, something like that, where they used it for a couple, 3 weeks, and the doctor stops and stops them without tapering, and they might feel mild flu-like symptoms and move on. In most cases, opioid withdrawal can be managed symptomatically with fluids, rest, acetaminophen, ibuprofen. But in detox settings, medications frequently used are clonidine, which is an alpha blocker, antihypertensive with sedative qualities, and that helps reduce anxiety and agitation. Dopamine agonists like Requip or Mirapex or Russell's Legs, that's another really common, very, very frustrating symptom of opioid withdrawal. Long-term opioid or persons withdrawing from long-term opioid dependence is restless legs, and that definitely interferes with their ability to sleep. So in detox and in programs, they often use Requip or Mirapex. Antihistamines like Benadryl to help with sleep, and buprenorphine, I'll talk more about that later, which is a mixed agonist-antagonist opioid that is approved for use in opioid withdrawal and maintenance. So we'll discuss that later. Opioid withdrawal in persons addicted to opioids can elicit a conditioned response to seek the drug obsessively, which is called a drug craving, and that again is facilitated in the brain by the nucleus accumbens and the VTA in the frontal cortex. And drug cravings can be a huge reason that people relapse also. They can be very pervasive, and although they don't last that long, in somebody that's physically not feeling well and hasn't slept, and those become very distressed. So let's move on to talk about discussing opioid abuse, dependence, and addiction. All right, so I'm not going to spend a lot of time bombarding you with statistics. Personally, my eyes glaze over whenever numbers are mentioned. So I'll give you the same respect and go easy on the stats, but there are a few up on the slide you can look at. So abuse of alcohol, abuse of addiction, alcohol, nicotine, and illicit and prescription drugs cost us about $7 billion a year in increased healthcare costs, crime, lost productivity. And every year, illicit and prescription drugs contribute to the deaths of more than 90,000 Americans. So just to put that in perspective, tobacco is linked to about 480,000 deaths a year. So nicotine addiction is a big issue too. How did the opioid epidemic begin? So that is a whole presentation in itself, but I'm going to give you a couple of key events that occurred that I believe are responsible for the upturn in opioid abuse and overdoses and misuse. First was the recognition of pain as the fifth vital sign. From this came the attempts by physicians and healthcare providers to continually ask patients about their pain levels, which, remember, are subjective, and the prescribing of opioids to manage that reported subjective pain. Physicians and hospitals were concerned about their patient satisfaction ratings, and if the patient did not have their pain managed well, whether in the physician office or the hospital floor or ED, here come the complaints and the poor HEDIS scores. So there were also increases in the use of opioids like Vicodin to treat pain of every type and severity. How many of you out there have been given a prescription for an opioid for just about any condition that might cause pain? Root canal, Vicodin. Ankle sprain, Vicodin. I got a headache, here's some Vicodin. You kind of get the picture. They're not hard to get, but physicians are not at fault here. Absolutely not. They were only trying to do the right thing with oftentimes little training and education on opioid prescribing and the risks of overprescribing. The general public were also at fault in that too. When they get a prescription of 30, they take 5 or 6 and they throw the rest in their medicine cabinet where their daughter, their son, their granddaughter, their grandson, or their granddaughter, grandson's friends, or people that are visiting that person look in the medicine cabinet, see those drugs sitting there, and take them for their own use. So we have the pain is the fifth vital sign, overprescribing of opioids, and now comes Purdue Pharma and OxyContin in 1996. Now, OxyContin, which is a time-release oxycodone, was marketed as the greatest thing in pain management since, well, whenever. There was an aggressive, actually aggressive was not the word, it was combat strength marketing of their drug to physicians. The physicians were told that OxyContin was less addictive because it was time release and that its benefits far surpassed other drugs and any risks that might be considered. It was even referred to as less addicting in some of the early literature. We now know that this is not true. For many, OxyContin, Vicodin, etc., were their first initial exposure to opioids and then subsequently addiction. For some, or overdosing, for some people. For some, it was death. Appalachia was hit very hard by OxyContin and other preparations like that. I'm sure you guys all heard this, that they referred to Appalachia, OxyContin was referred to as hillbilly heroin. Combined with that, the influx of cheap Mexican heroin from many of the drug cartels, that also contributed to the epidemic. So when increased public awareness and law enforcement efforts put a curb on the availability of OxyContin and other Schedule II opioids, many of the people that became addicted through prescription medications turned to heroin. Heroin use is on the rise because of increased diversion controls of Schedule II prescription medications. Abuse deterrent formulations and resultant increases in street prices for opioids. Now, abuse deterrent formations are where they make a drug less likely to be abused by putting it in a plastic matrix where it can't be crushed or melted down. OxyContin was huge because they crushed it and snorted it and injected it. So the new formulations of OxyContin were made so that you couldn't crush it. Literally, you could take a hammer and smash it and it wouldn't break. And they put them in like plastic matrix that would like distribute the drug in your digestive tract, and then you would just void the little matrix that it was in. So heroin now averages about $100 a gram. 1 gram contains about 10 packs of heroin, so it's about $10 a dose, $10, $15 a dose, which is much cheaper than one OxyContin, which typically may run between $30 and $45 on the street. Michigan continues to be a source state for diverted prescription drugs, which are distributed to Indiana, Ohio, Kentucky, Pennsylvania, the entire Midwest. Street prices for diverted prescription meds run, as I just mentioned, about $30 to $45 in Michigan, but may sell for double or triple their value when distributed to other states. The most commonly diverted opioids are Vicodin, OxyContin, Dilaudid, and methadone. And just so you guys probably all know that Vicodin has since been placed in a Schedule II designation by the Drug Enforcement Administration. It used to be Schedule III, and because of the opioid epidemic, the DEA pushed to have that put into a Schedule II, which makes it there's much more scrutiny on prescriptions that are written for Schedule II medications than there are Schedule III and below. So this is only a high-level picture of how the opioid epidemic progressed and mutated into what we know today. There are other socio-economic and cultural influences. How many of you heard of drank or syrup? This refers to a drink favorite of rapper Lil Wayne, which is promethazine and codeine cough syrup mixed with Sprite or Mountain Dew. So there are cultural influences that play a part in opioid addiction too. And so kids see rappers promoting the use of opioids at times, and they see messages that condones that use. So we could devote an entire presentation to discussing how we got to this point, but we're going to move on to discussing opioid abuse and dependence. Okay, drug abuse. Drug abuse is defined as the misuse of prescription medications or the recurrent use of illegal mood-altering substances. Drug abuse or misuse does not imply addiction. However, continued use of substances can lead to addiction. So opioid abuse would be the non-medicinal misuse of opioids, whether the opioid is prescription or illegal, and the use of which causes consequences, which can include occupational, social, financial, familial, and legal consequences. So people use substances for a variety of reasons. It becomes drug abuse when people use these illegal drugs or legal drugs inappropriately. So this includes the repeated use of drugs to produce pleasure, alleviate stress, and or to alter or avoid reality. It also includes using prescription drugs in ways other than prescribed or using someone else's medication, a big problem. Addiction occurs when a person cannot control the impulse to use drugs, even when there are negative consequences. The defining characteristic of addiction. These behavioral changes are also accompanied by changes in the brain functioning, and we talked about that earlier in the brain's, the reward centers, and the ability to recognize when you are getting into trouble. So let's delve a little deeper into the topic of the dependence and addiction, and a little later we'll look at the distinction between abuse and addiction. So, what is addiction? Is it physical dependence? Is it a lack of willpower? Is it an immoral condition or a character disorder or brain disease? So this is the $100,000 question. Some people think addiction is the physical dependence on opioids, while others believe it may be a lack of willpower or the will to stop using opioids. Some believe it's a moral question, a sign of poor character. And the bottom line is many researchers believe it is a brain disease. So let's look briefly at each of these theories and see if we can determine an answer. So we'll start with physical dependence. Physical dependence is not equivalent to addiction and may occur with irregular use of many substances, legal and illegal, even when taking prescribed. We talked about that a little earlier. It occurs because the body adapts to the regular exposure to that substance, and when that substance is taken away, symptoms can emerge while the body readjusts to the loss of it. So physical dependence can lead to craving to relieve the symptoms of withdrawal, and opioid addiction is likely may include physical dependence, but must also meet additional criteria. So it's really not physical dependence. So is it a lack of willpower? So many important historical figures across the ages have addicted to illicit and illicit substances. Adolf Hitler was a well-known amphetamine addict. John F. Kennedy, same thing. Winston Churchill was addicted to alcohol. And Miles Davis, one of my favorite trumpet players, heroin, cocaine, alcohol, and sedatives. But none of these men could be considered as lacking in willpower. I don't think any of us would say that these men are lacking in willpower. So is it an issue of amorality or character disorder? Addiction is not a moral affliction. Sigmund Freud's recommendation to his patients to use cocaine was a product of the prevailing wisdom of the time. That use cocaine is a non-addicting substance having therapeutic value. Other notable historical figures that struggled with addiction are William Buckley, well-known, both revered and reviled, conservative thinker, became addicted to barbiturates, alcohol, and Ritalin in later life. Pope Leo XIII. Now, Pope Leo lived 1810 to 1903, and he was addicted to Zin Mariani, a red wine that contained coca leaves, and Benjamin Franklin. The father of electricity was known to be addicted to laudanum, which was an elixir containing opium and alcohol. In fact, laudanum was quite popular at the time in the late 18th century and was available commercially without a prescription. That's a lot of interesting reading. If you want to look at the history of opioids in America, it's a fascinating read about how a lot of opioids in the 1800s and the real early 1900s were available without a prescription and in a lot of patent medicine preparations. So we come to the final consideration. I think that addiction is a brain disease, and here's why. The American Society of Addiction Medicine defines addiction as, quote, a primary chronic disease of brain reward, motivation, memory, and related circuitry. Remember nucleus accumbens and the ventral tegmental areas? Dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. This is reflected in an individual pathologically pursuing reward and or relief by their substance use and other behaviors that are generally related to the pursuit of that drug of choice. Interesting. So addiction is characterized by the ability to consistently abstain, stay clean, impairment in behavioral control, cravings, diminished recognition of the significant problems that occur with your behavior while attempting to get used and hide the fact that you're getting high, and interpersonal impairment in interpersonal relationships. So like other chronic diseases, addiction often involve cycles of relapse and remission. Without treatment or engagement in the recovery activities, addiction is progressive and can result in disability or premature death. So the hallmarks of addiction are the 5 C's: craving, compulsion, loss of control, continued use despite negative consequences, and chronic use. As you can see, tolerance and withdrawal are not included in that definition. Remember, too, that addiction is not only always related to opioids. Tobacco dependence, overeating, compulsive sexual behaviors, gambling, obsessions and compulsions to pornography, all these things manifest themselves in the nucleus accumbens and the ventral tegmental areas with decreased frontal cortex involvement, which means it impairs our judgment and insight. So therefore, when we view addiction, we need to remember that opioids are not the only substances or behaviors that are mediated by the brain and the reward pathway. Addiction also includes other biopsychosocial determinants, biological. There's a belief that genes may influence the metabolism of psychoactive substances, brain reward pathways, the age, race, gender, route of administration. It is believed that some people develop addiction due to deficiencies of dopamine processing or production, and that's called reward deficiency syndrome. Or is those people with addiction simply have low dopamine because they burned out their pleasure center? So again, more research needs to be done in this. There was an experiment that was done with volunteers who were injected with IV methylphenidate, which is Ritalin. Most did not enjoy the experience. However, those that enjoyed it, the researchers found that they had lower levels of dopamine in their brain. So the idea that maybe there's a dopamine the idea of that reward deficiency syndrome. So addiction can also be viewed as an abnormal response to reward. And this leads to the idea that some individuals are predisposed to addiction because of the abnormal response to reward caused potentially by deficiencies in dopamine or decreased dopamine receptors in the brain. And it's known that decreased dopamine receptors equals decreased dopamine. And that also causes a syndrome called decreased hedonic tone. And hedonic tone is the general level of pleasure we derive from normal activities. So if a person has low hedonic tone, i.e. low dopamine, they may be more prone to the development of addiction. Psychological determinants can be seen as including trauma of any kind. And a lot of you that are in the treatment field see now that there is a new focus on trauma-informed care, recognizing that trauma has a big place at the table when talking about the development of addiction and the treatment of people with chemical dependencies. Our personality makeup can also influence the development of addiction. Our innate or learned coping abilities or lack thereof. Social determinants can also include familial exposure to drugs and alcohol, negative peer group influences, environmental conditioning such as residing in high drug trafficking areas or drug using areas, and we cannot forget our popular media that encourages self-medication, alcohol use, and finding immediate remedy in prescription medications. And then there's celebrity endorsement of drug-using lifestyles, and I mentioned that earlier with Drank or Purple or Disrupt. Okay, abuse versus addiction, really simply. Before we move on, I wanted to complete this kind of cycle and talk about the abuse talk a little bit about abuse versus addiction by pointing out the differences between abuse and addiction. So in the older DSM manuals, there were distinctions between abuse and dependence. Now the new DSM lumps both of these under substance use disorders, and there are pros and cons to this approach. Most people with drug or alcohol problems can stop using on their own or with minimal assistance from counseling and 12-step programs. Remember, it's the 5 C's that define who is considered an addict: compulsion, loss of control, craving, continued use despite negative consequences, and chronic use. Simply drinking or drugging too much does not constitute addiction. But you can develop tolerance to become physically dependent. You can develop tolerance to become physically dependent on a substance without becoming addicted to it. We talked about that a little earlier. Okay, so we're going to move on now. Jeff, want to put it forward here. Thank you. We're going to talk now about treatment modalities. Actually, I was going to talk just briefly about detoxification
I think one of my slides is missing, but that's okay. I was going to talk about detoxification and outpatient. We're talking about treatment modalities for treating opioid dependence. Detoxification typically done, there we go, thanks. Typically done in a hospital or inpatient setting, but it can be accomplished as an outpatient with physician monitoring. Detoxification can be done with replacement therapy, methadone or buprenorphine, or other medications that I mentioned earlier. Nutritional supplements, supportive care. Inpatient rehabilitation. Now, when we talk about inpatient rehabilitation, it is usually, for most folks, habilitation due to the lack of functional abilities prior to entering in treatment. When I worked at a couple of inpatient treatment centers, most of the folks that came into treatment, basically including me when I went through treatment, I had no functional abilities to cope with anything. So I was not really rehabilitated, I was habilitated. So, I mean, that's something to consider. And so inpatient rehabilitation is a variable length of stay, structured program, inpatient setting, freestanding rehabilitation, or hospital unit-based setting. They provide education, detoxification if needed, relapse prevention strategies, disease management, and development of recovery-oriented systems of care that can be used to maintain abstinence. The cost of inpatient care can range from several hundred to several $1,000s, depending on the facility and the length of stay. Commercial insurance, Medicare and Medicaid cover inpatient stays if medical necessity criteria are met. Outpatient is typically abstinence-based, but can include use of medications. And we're now going to talk about medication-assisted treatment, or MAT. MAT is medication-assisted treatment, utilizes older drugs such as methadone and newer ones such as buprenorphine and naltrexone in the treatment of opioid addiction and dependence. Buprenorphine is a relatively new development in the treatment of opioid addiction after NIDA-supported clinical research showed that it was a safe and effective treatment. And in 2000, Congress passed the Drug Addiction Treatment Act, or DATA, which permitted qualified physicians to prescribe narcotic medications. Now, the way it reads, it says narcotic medications, schedules 3 to 5 for the treatment of opioid addiction. Currently, there is only one medication that is allowed to be prescribed by physicians, actually two. One is buprenorphine, one is naltrexone, one is psychoactive, one isn't. But the legislation caused a large paradigm shift by allowing access to pharmacotherapy for opioid addiction in primary medical settings, the physician office, rather than limiting it to specialized drug treatment clinics or methadone clinics. So buprenorphine is a mixed opioid agonist-antagonist, which means it acts like an opioid in the brain, in the neurotransmitter system, and the reward center, but at the same time it has properties that will cause opioid withdrawal if given to an individual dependent on narcotic agonists. Now, narcotic agonists are your typical opioids: heroin, morphine, oxycodone. Those are all considered pure agonists. Buprenorphine is a mixed agonist-antagonist. Just for point of reference, naloxone or Narcan is an opioid agonist, a pure agonist. It will cause withdrawal symptoms if you give it to somebody who is addicted to opioids. Buprenorphine is administered once opioid withdrawal symptoms are present and can be used for both detox and maintenance therapy over a longer period of time. The good thing about buprenorphine is that it causes less respiratory depression than typical opioids, and it's a safer risk profile, and there's less risk of overdose with buprenorphine. It is a Schedule III controlled substance, and like methadone, it can block the euphoric effects of heroin or other opioids at prescribed doses, which makes it an effective tool in the treatment of opioid addiction. Another positive benefit of buprenorphine is it's a ceiling effect, meaning that increased dosage does not produce increased euphoria. This becomes beneficial when tolerance to the euphoric effects are achieved. So it means that, like with methadone, you can keep getting to a higher dose, and you can get greater opioid effect, and you have a little bit of a high or whatever you get from that. And with buprenorphine, there's a ceiling at that. I think it's about 16 to 24 milligrams is the highest dose they recommend. And after that, the more you take, you don't get more euphoria. At stabilized doses, there is generally little sedation or impairment of cognitive functioning. Okay, methadone is the old school medication-assisted treatment. It's a synthetic opioid agonist used in the treatment of chronic addiction. It's taken once daily. It can block the euphoric effects of heroin. It can also be as addictive as heroin and be diverted to illicit use quite easily. Methadone maintenance is generally viewed as an effective treatment strategy in that it allows the individual to interrupt the cycles of euphoria, crash, and craving that is the hallmark of heroin and opioid addiction. Naltrexone is an opioid blocker that, when administered, will block the euphoric effects of any opioid-type drug at the receptor level. So, but it does not have any, it's not an opioid, it's not an agonist or an agonist-antagonist. It doesn't have any opioid-type properties. Naltrexone is effective for those individuals with a strong recovery support network in place and positive internal motivation for recovery. In oral formulation, it needs to be taken on a daily basis to be effective, and there's also an intramuscular depot formulation that can last up to 30 days. So naltrexone has been used effectively in treating healthcare professionals with addictions in conjunction with health professional recovery programs. Naltrexone has also been used in the treatment of alcoholism and has been shown to reduce alcohol craving in certain individuals. So, briefly, that does work. With methadone, there have been many studies since 1965 that have shown the efficacy of methadone for all those areas. Decreased death, decreased reduction in IV drug use, reduction in seroconversion to HIV, reduction in relapse to IV drug use, and it is a harm reduction strategy. So from a strictly harm reduction perspective, medication-assisted treatment using methadone does show prodigious results. Buprenorphine. There was one study by Phelan in 2008 that he had 53 people in treatment. Treated with buprenorphine showed that 91% were negative for other opioids. 96 were negative for cocaine, and the satisfaction scores were pretty high. There was good retention in treatment, and the patients in the study were treated in primary care office, which allowed them to, set appointments up at their convenience instead of having to be at a methadone clinic at certain days and times. As I mentioned earlier, the DEA allows office-based treatment with buprenorphine only after registration and basic education for the physician. So for those in the addiction field, especially those who maintain that abstinence-based treatments are the standard to which all addiction treatment should be modeled, they dispute the efficacy of medication-assisted treatment, stating that it is simply replacing one addictive substance for another, that it does not allow the brain to return to normal functioning or allowing the receptor and reward systems to regulate. The patient is lulled into a false sense of security that they are really in recovery, and that harm reduction is not enough, that the patient must be involved in abstinence-based recovery in order to be considered in recovery. Some 12-step groups expressly discourage members from taking any type of mood-altering medications, claiming that drug-free recovery is the only model that has been shown to work. Another consideration is what happens to patients on medication-assisted treatment when they elect to discontinue the medication. Studies with methadone and buprenorphine do not point to an encouraging picture. Many who voluntarily or involuntarily stop do experience relapse to opioids. So, what do you think? Some things I want to leave you with to think about this. Is medication-assisted treatment really recovery? How would you define recovery? What constitutes recovery? Is it abstinence-based, 12-step model? Is there room for math? What place does harm reduction have in the discussion of recovery from addiction? Harm reduction occurs when people are abstinent also. If you're not using and getting high, there's harm reduction there too. And research has shown that reward and brain functions in those addicted to opioids and now in recovery continue to show deregulation and impairment of the reward centers months after the last use of opioids, with drug craving, anxiety, impaired sleep prominent. So these prolonged symptoms frequently lead to relapse. It has been proven that medication-assisted treatment increases treatment retention, patient satisfaction, and reduces the use of other opioids and other drugs. So, Nicotine replacement is the gold standard in tobacco dependence. Not many would contend this to be controversial or unethical, so why would that sometimes be considered bad or unethical? So, my personal view is that that doesn't replace at the table when discussing recovery-oriented systems of care. I believe that harm reduction is an important objective in the treatment of opioid addiction, especially those who use injectables. The neurobiology of opioid addiction presents a unique and formidable obstacle to recovery that can be assisted by the use of MAT. I believe that each individual should be given the choice to choose the route of recovery that best suits their needs, and that MAT should be an option in most situations. So this discussion of what constitutes recovery would be in another entire presentation. So I do want to stop and move on right now, and my last section here is going to be relatively brief, and I know we have a few minutes left. I probably won't have time to do Q&A, so if you have them, please put them in the chat box, and I will respond to you by email and give them to you. So efforts to combat opioid misuse and overdose, there are law enforcement efforts, national and state efforts, and community efforts. Law enforcement efforts include they're called high impact drug trafficking areas, and Michigan is included in that. Specific areas that receive federal funding to address drug trafficking organizations and money laundering operations. So it's a joint effort with DEA, Drug Enforcement Administration, Alcohol, Tobacco, and Firearms, Homeland Security, IRS, Michigan State Police, Detroit Police Department, sheriffs across the state, the Postal Service, U.S. Customs and Border Patrol, Coast Guard, and Secret Services. There are 28 high-intensity drug trafficking areas nationwide, and Michigan is important because of our borders and interstate highway system that link us to Chicago, and the southern states via I-75, which is called the Heroin Highway. Prosecution of prescribers has also increased. The Drug Enforcement Administration Office of Diversion Control website contains information on prescribers who have had their DEA-controlled substance licenses revoked or suspended for overprescribing and or diverting prescription medications. In many of these cases, the physicians have faced criminal charges. There are also prescription drug monitoring programs, PMPDs, are highly effective tools in reducing prescription drug abuse and diversion. PMPDs collect, monitor, and analyze prescribing and dispensing data that are submitted by pharmacies, and physicians. Now in Michigan, all three states, Minnesota, Wisconsin, Michigan, all have PMPDs, but at this point, I don't think any of them are mandatory reporting. So it's up to the clinician, the practitioner, and the pharmacy to take place. Most physician offices are becoming aware of this and are using prescription monitoring programs to see if patients are getting medications from other sources, and pharmacies are reporting the dispensing of these medications into the PMPDs. The PMPDs are proactive. They safeguard public health and safety while supporting legitimate use of controlled substances. They do not infringe upon the legitimate prescribing of controlled substances by a practitioner acting in good faith and in the course of professional practice. So 49 states currently have an active PMPD. 15 of them collect only Schedules 3 through 5. 36 others, including Michigan, Minnesota, and Wisconsin, collect data on DEA Schedules 2 through 5. This is important since most abused opioids are in Schedule 2. Naloxone. This is also known as Narcan and is a medication called an opioid antagonist used to counter the effects of opioid overdose, and it's usually used in injectable form, but there are preparations now available for use as an intranasal administration to be used by first responders and the general public in intervening in an overdose situation. So it is a non-scheduled, meaning non-addictive prescription medication that only works if the person has opioids in their system. The medication has no effect if they're not in their system. And although typically administered or traditionally administered by emergency response personnel or people in the EDs, Naloxone can be administered by minimally trained lay people, which makes it ideal for treating overdose for people who have been prescribed opioid pain medication and for those who abuse heroin and other opioids. It has no risk for abuse, and it may be injected in the muscle vein or under the skin or sprayed in the nose. And it is temporary. It's 20 to 90 minutes. So it can be used by first responders, family, and friends of opioid-dependent persons. Now, 40 states have passed laws facilitating access to naloxone. The most recent Michigan Prescription Drug and Opioid Task Force recommendations included making naloxone available to the general public by use of a registry similar to the way pseudoephedrine is now dispensed in Michigan. So if you're 18 years old and you go to a pharmacy, you sign a registry, you pay the fee, and they give you the intranasal version of it. They would be getting the injectable version. There is a preparation of the injectable version of Narcan or naloxone that is it's a syringe that can be used by a layperson, and it activates only when you press buttons, and it gives you instructions on how to use it. But I think generally what they're looking at is the intranasal version. So the current cost on naloxone intranasal preparation is about $40 per dose, and we'll see more of that moving forward. Opioid prescribing guidelines are being developed and have been instituted by the CDC this year, actually. Health plans, hospital systems, emergency departments, and individual practitioners can follow opioid prescribing guidelines to reduce the overprescription of opioids. Massachusetts recently enacted legislation to limit opioid prescribing, so first-time prescriptions there can be only up to a 7-day supply, and the prescriber must check the state's prescription drug monitoring website to make sure the patient is not receiving opioids from other sources. There are also, and I'm running out of time here, there are also task force, there are also prescription drop boxes, drug buybacks, or drug takebacks, not buybacks, it's drug takebacks. And the next DEA-sponsored take-back day is October 22nd from 10 to 2. And the final thing is drug courts. They operate similar to DUI courts, where first offenders can be put into a court to avoid incarceration, and they follow the court's guidelines for recovery. So I think what right now is we'd like to have the operator please put on the evaluation. So those of you that are getting CEs, you don't have to do the evaluation on the screen, and I will tell you how to go ahead and get CE information. So in Michigan, because we have 3 states involved with this, there's 3 different ways to do it. In Michigan, you will go to the website that is now posted in the chat box, education.mpro.org. And you will log in using your existing password or create an account. You will go to the title of today's presentation, and the codes are listed there. Opioids, social work for social worker, opioids, RN for nurses, and you will take the evaluation and get your certificate. Now, the link will not be active till tomorrow. I don't know why that is. It's just the way we have to do it here. So don't try to do it today. You have to wait till tomorrow to do that. And for Minnesota and Wisconsin, for nursing, social work, or if anybody out there wants a certificate of attendance, you can go to the website that is in the chat box there, follow the instructions, and you will take the evaluation, and you will get your certificate. Now, for Minnesota and Wisconsin social workers, you will also have to take a 10-question test, which is a requirement of the NASW in your state. That wasn't our doing. I'm sorry you have to do that, but they consider this a long-distance learning event, so you'll have to take a brief 10-question test and the evaluation to get your certificate. The presentation and slides will be available in about a week on our LSQN YouTube channel, and Jessica posted that in chat. Thank you so much for that. I know I went a little over and kind of jammed that stuff in at the end. Thank you so much today for your attention, and I hope you found this informative.
I believe this is it. So, ladies and gentlemen, this completes your conference call. You may all disconnect and have a great day.